गुड इवनिंग एंड अ वेरी वार्म वेलकम टू द ब्लैक होल। सेहत की जब बात की जाती है तो उससे महज जिस्मानी सेहत मुराद नहीं होती, बल्कि उसमें मेंटल या साइकोलॉजिकल वेलबींग जो है वो भी निहायत अहम एक आंसर है। और यही आज हमारी गुफ्तगू का मौजू है, माइंड मैटर्स, डिस्पेलिंग मेंटल हेल्थ मिथ्स। सो टुडे वी विल डिस्कस द myths and mysteries surrounding mental health, and we will try to debunk some common misconceptions to develop a better understanding of our psychological well-being. We are very grateful to our speaker, Dr. Shahid Latif हैं आज हमारे साथ. He is a consultant psychiatrist and medical director at St. Matthew's Healthcare in UK. Moreover, he is the current chair of the British Pakistani Psychiatrist Association. Also, he is on the BBC Asian Network's panel of experts for mental health and hosts a locally based radio health show, and regularly features on TV programs in the UK and Pakistan on issues related to mental health, including working on mental health policies with the Pakistani government. Moreover, he was appointed fellowship by the Royal College of Psychiatrist in 2017 and received Clinical Excellence Awards in 2012 and 2018. ये अभी मैंने काफ़ी शॉर्ट करके बायो इनका बताया. बिफोर वी स्टार्ट द सेशन, प्लीज़ डू अस अ फेवर लाइक ईच डे के अपने सेल फोन जो है वो साइलेंट मोड में कर लें. व्हेन द हाउस इज़ ओपन फॉर Q&A, जस्ट रेज योर हैंड और माइक्रोफोन अपने हाथ में आने के बाद आप इस गुफ्तगू में शरीक होइएगा. सो लेट्स वेलकम डॉक्टर शाहिद लतीफ़. थैंक यू.
Thank you. Good evening and Assalamu alaikum to everybody. It's wonderful to be here in Pakistan and wonderful to be here having been introduced to the black hole. It's absolutely fantastic. Thank you to Professor Saab for the invitation, and thank you to all of you for attending. Yeah, नीचे आएगा ये screen जो है. Maybe we can start the presentation. Thank you. Thank you. Thank you. Okay, so today जो आज हम बात करेंगे, it's basically, as the heading says very rightly, कि mental health. So we all aware, just like our own physical health, जिस्मानी सेहत जो हमारी है, उसी तरह हमारी नफ्सियाती सेहत होती है. और जिस तरह हमारे बाजू हैं, मसल्स हैं, हार्ट है, किडनी है, लिवर है, उसी तरह ब्रेन भी है. और ब्रेन का भी कॉन्शियस और अनकॉन्शियस प्रोसेस चलता है, जिसकी वजह से हम लोग डे टू डे हमारी जो इमोशंस हैं वो इम्पैक्ट करती हैं हमारे डे टू डे फंक्शनिंग पर. हमें पता नहीं चलता क्योंकि हम लोग एक ऑटो पायलट पे चल रहे होते हैं. और कौन कौन सी चीज़ें जो हैं जो ऑटो पायलट पे हमें रखती हैं, हम थोड़ा बात करेंगे उसे. लेकिन आई थिंक जो आज थोड़ा सा रूडिमेंट्री किस्म का इंट्रोडक्शन है मेंटल हेल्थ पे, जो आई थिंक जो डिस्पेल, और ये क्वेश्चंस वो हैं जो अक्सर मुझसे पूछे जाते हैं. वेरी बेसिक क्वेश्चंस. हम लोग वहाँ पे कम्युनिटी में भी इसी तरह के लेक्चर्स करते हैं जो बिल्कुल ही बेसिक लेवल पे, और हमें ऐसे लगते हैं एज अ एक्सपर्ट इफ़ यू लाइक इन मेंटल हेल्थ, हम समझते हैं कि हम लोग एक डिफरेंट लेवल पे बात करें, पिच करें. लेकिन व्हेन वी गो डाउन टू द crux of it, it's basically what we miss is the very basics of mental health and what it is, and some of the misconceptions around mental health. Does it exist? Does medication work? What is therapy? What kind of illnesses are there? If somebody touches something repeatedly or likes to do something, does that mean they're OCD, etc.? You know, very, very basic stuff. But we'll open things up later on and as part of the Q&A session. So I just want to start off by just asking the audience here that here is a Coke ad. There's a chap who's lying in the desert. He drinks a can of Coke, refreshed, rehydrated, and there you go. Unfortunately, this didn't work in countries. For example, the Middle East. Although there's a desert there. Any idea why that might be?
I think the sweetness and the drinks can. मेरे ख्याल में कि ये जो कोई भी ड्रिंक हो मैं नहीं कहता कि स्पेशली कोक या कोई भी ऐसा फास्ट फूड खाने के बाद आपका मूड वाकई ही अच्छा हो जाता है,
ठीक है, ये एनर्जी आती, ठीक
ये
है,
एक एनर्जी आती है।
ठीक है, ठीक है. Think slightly differently. Let me give you a clue.
Can I say something?
जी जरूर जी.
Maybe lying down is supposed to be leisure and एक happy state, और भागना एक मेहनत मुशक्कत है.
Very good. So you are thinking more from a cultural perspective, Anna. Let's keep that note open. So we are talking about this direction. इस डायरेक्शन में भी दबा सकते हैं ना. उर्दू किस लैंग्वेज पढ़ी जाती है? And Arabic and Urdu, a lot of other languages. ठीक है? Now, although in the Middle East, not everybody would see it that way. Like, the point I'm trying to make here is how easily we can miss things. When we put things out there, we think from our own perspective. ठीक है? हम एक boxed thinking के हिसाब से सोचते हैं. And this is part of our own psychological makeup. Unless we are not conscious of what we are doing, we can fall into these mistakes. And there are a lot of marketing mistakes. For example, एक jar of Africa में एक jar था, उसके ऊपर एक बच्चे की शक्ल, बच्चे का खाना था, तो उसके ऊपर बच्चे की शक्ल बनी हुई थी. In one, I don't know which, in African country, anything that's inside the jar, the picture of it will actually be on the jar. In that particular country, obviously it's the kid crushed in there. I mean, would it actually work? So, you have to understand there's a psychology behind everything, an understanding, a consciousness, and culture plays a big part. And I'm saying that on purpose because we are living in Pakistan where there is a certain culture, certain belief systems which we'll come to later on. Okay, I just want you to have a read of this, and I want you to tell me how this works. Okay, a mother and a daughter are involved in a road traffic accident. The mother dies. The daughter is taken to hospital due to her injuries. On arrival in the hospital, one of the nurses sees the girl and says, "That's my daughter." Is that possible?
Yes, because the concept is the nurse could be his father.
Fantastic, excellent, excellent. You see, ये समझ आइए इन्होंने क्या कहा है? The nurse is actually a male. You see, how often can we automatically put a nurse into the position of a male or a female? Similarly, if this was a surgeon came and said, "Hey, that's my son or daughter," and we said the father passed away. So you can very easily, again, so well done. I mean, you've picked it up really well. लेकिन इसमें we can very easily get trapped into some of the very basic things. तो लोग कहते हैं कि हमारा जो दिमाग है over the years, over the decades, over the centuries, हमारा develop, evolve हुआ है, बेशक हुआ, but has it actually evolved because of the advances in technology, or is there any other reason? I remember somebody said to me कि बहुत ज़्यादा हमारा primitive दिमाग होता था and we've evolved over time. A lot of people get this wrong. This is something that was shared with us in a presentation in the UK, and even those white counterparts, my colleagues, even the first thing it took them a bit of time of thinking, so they had to think outside of the box. Although they live in a society where they are both male and female nurses, but it took them a little bit of time. So I wonder, why is that happening? Why is it that when they are living in that society, the mind is primitive still? Is it still thinking? Is it advanced as we think it is? So it just got. So I wanted to put this up on purpose just to get you thinking as a starting point. कि हम लोग जब किसी चीज़ के बारे में सोचते हैं, it's not all that we think it is. ठीक है? It's slightly taking a step back, coming out of our autopilot mode and bringing more consciousness into the process. Okay, so I'm going to go straight on to some of the questions that we often are asked. Some of them are my own, many of them we often get. So is mental illness a rare thing, or do you think it's common?
In Pakistan it's common.
In every way it's common. Pakistan is no different from WHO when they have done their surveys and studies. Samia, who's a public health physician, she'll be able to tell you from WHO the reading, which are the rates that come back. It's 1 in 3 people sometime in their life will experience depression.
What is mental illness?
We'll come to that. Good question. The next question is does depression actually exist? कह तो दिया कि 1 in 3 people will experience depression. Thinking, does depression exist, or is it just a misnomer? Same with anxiety. 1 in 3 people again. A very, I worked in forensic psychiatry. When I say I worked, I trained. When I was training, I worked for a couple of years as a forensic psychiatrist. So one of the common things that people would often ask me when they asked me when I was working in forensic psychiatry is, are those people who suffer more prone to violence, or are they more dangerous? Kya khayal hai, is that true? Depending on their illness, yes. The answer to that is no, they are not. Again, this is a misconception. The only thing you do get is that when people do experience psychological problems or do have that tendency of experiencing psychosis, they're, number one, what they partake in may be more violent than the normal. And number two, because the concept of mental illness is attached, that label is attached, that's why it gets more highlighted. Okay, that's why people have the concept that people who do suffer from a mental illness do have, are more prone to violence. That actually is not true. It's a misnomer.
Excuse me?
Ji.
What do you mean by what they partake in? What do you mean?
For example, agar kisi ne, if somebody's taking an average Joe blog, is partaking in, for example, any kind of violence, someone with a mental illness would do something which would be more extreme in that. Not more, they would do it, they will be more extreme and it will be more prevalent in your face. And because of the presentation of it in the media and the mental illness that comes with it, obviously will automatically be linked with that. Okay?
Are we allowed to ask questions in between?
Of course.
Yeah, but you have to.
Mike.
The mic. Oh, okay.
But that's allowed, right?
जी 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 ज़रूर ज़रूर.
Doctor साहब, जो पहले वाला question था, right? That was actually a schema between gender, the question that you asked. But if you take that and apply that, has science actually found out other schemas that are correlational to that perspective, right? Because really the answer is just this, that gender schema was incorrect. But if you take that at a larger scale, are there other schemas that science has found out?
There are lots of schemas. Obviously, especially the reason why I put this one up is just number one, to wake you guys up. and number two, also just slightly think out of the box. Okay? हम जब audience में बैठे होते हैं, जो सामने एक चीज़ होती है, we assume things. But actually, I mean, you got it right, but I'm just wondering, if you hadn't got it right, it would have been interesting to see what the others would have thought and whether it would have been the first thing that came to their mind. If it didn't come to their mind, then what is the reason for that? Ultimately, we would have come for it. And my experience is, having asked that questions in different places, it doesn't immediately. You're one of the very few who've actually responded correctly to that very quickly. But normally we go around and it takes about a good 3-4 minutes before people, and they will say, acha, wo stepfather hoga, ye hoga. That's the kind of conversations we normally get into. But that's not the point. The point is actually, when you talk from a schematic perspective, the point actually is that why do we actually put people in a box? We stereotype. What's the reason behind that? Schemas the बहुत ज़्यादा इस तरह के stereotype ही के. Lekin why do we actually do that? That's what I'm trying to raise here. Okay? So it's the consciousness of it. Does that answer your question? Okay.
Either people or studies are not integrated and they can based on research.
Yeah. Okay, so the next question I normally get, those with mental illness have personality flaws, are weak, or lack willpower. So people with mental illnesses, people often say, कि weak हैं, या lack willpower, या they have personality flaws. Again, when we come to it in a moment, or maybe we can discuss it, this is actually not true. There may be certain elements depending on what their personality is like, but when you get a full assessment of the patient, if you get a detailed assessment, if you sit down with an individual and go through their process of majority of the patients, some people who will skew it, but majority of the patients who we see, they do not have personality flaws and they do not have lack of willpower. That may happen because of the mental illness, but the mental illness doesn't happen because of lack. Because majority of the mental illnesses, when we talk from a scientific perspective and when we talk from a neurochemical perspective, they do exist. There's a reason. Work is ongoing in relation to the theory, the molecular, the genetic basis of the theory of it, but there is a chemical imbalance that occurs, and it's not because of a personality flaw. Personality may personality vulnerabilities may contribute towards it. Different person, if one person has the same kind of experience or trauma, why doesn't person B experience the same kind of mental illness or anxiety or disorder? And the reason for that is because every person is genetically built differently. But it's not because of any personality flaws, it's not because of weakness. There may be certain vulnerabilities, something within their genetic makeup, something genetic loading that they have, something within their previous history of what they may have experienced, but they are not flaws or weaknesses within the personality. There's a difference. This is often a question we get, that all freaks have OCD. Now when they see by freaks, the reason I'm asked use that word because people often say that. And it's very easy to say कि यार मेरा दोस्त है यार वो बार बार ये करता है एक ही बात पे अटक जाता है यार उसको OCD है. OCD, the reason again it's just to shun that myth that OCD is when you have to diagnose it. Who knows what OCD stands for? You know, you're a psychologist.
Obsessive compulsive disorder.
Correct. Obsessive are the obsession, the thoughts, the ideas, impulses, images that come to the mind. And compulsion is when you act. Obsessive compulsive disorder. Okay, when it occurs, it can be very debilitating. It's a very debilitating illness. जो बिल्कुल mild end है उसका, mild end है, which is it could be just obsessional without the compulsions, but it is a mental. It does go into the category of a mental. When you diagnose this, it is considered a disorder. Okay, so remember, all of us can have within our personalities can have obsessionalities. कोई ना कोई किसी किस्म की कि अगर मैं इधर हूँ मुझे अच्छा लगता है मेरा फ़ोन इधर हो ग्लासेस इधर हो और मैं अभी I'm okay now. लेकिन अगर मैं ना करूँ ना ये I can still function. So anything that impacts on your day-to-day functioning goes from an order to a disorder. That's when it becomes a disorder. ठीक है, तो ये बहुत ज़रूरी है ये समझना इस चीज़ को कि just because we experience certain things, it does not mean that we have a mental illness or we have a disorder. So it takes certain criteria to go from an order to a disorder. So OCD is the same. If people like cleaning, like the house clean, or like the books in a certain way, or the house in a certain way, that's not an illness. If they can function. If they can't function, then it's a problem. And they can come into the mild, moderate and severe categories.
Sorry, another question.
जी, ज़रूर.
So when you say that, when you have a chemical imbalance, how do you actually judge between hereditary chemical imbalance and something that is physiological?
Very good.
Right? So you have a person who's actually stress related and you look at, XYZ things and there's a chemical imbalance. But the judgment is, was it hereditary or is it actually due to his physiological or even psychological stress? How do you judge that?
A very good question. Very good. उसमें देखें, obviously as psychiatrists, we do not do genetic testing on every patient to see whether it's genetic based, but we pick up these from three theories through a number of research that has taken place, some experiments that have taken place, where etiological factors for illnesses, why they occur, how they occur. ठीक है? So if you go into the understanding of the genetic basis, उसमें monozygote, dizygote वगैरह, you would probably know, ठीक है, twin studies वगैरह, and that's where they come out that these are genetic, उनको अलग कर दिया बचपन में इकट्ठा रखा. That's where the genetics. So a lot of studies have gone into, and whether it's not genetic, what we do when we take history from our patients, one of the things as part of the history, because for psychiatrists our bread and butter are not X-rays or CT scans or MRIs. Our bread and butter is mental state examination. That is, we sit down with patients and we go through a full history. A history which details and it picks up certain, and there are certain ways of picking up, and one of them is family history. In family history we talk about parents, we talk about relationships, we talk about siblings, we talk about relationships, and within that we also have to ask about family history. And the interesting part about that is that if you have a family relative who, for example, has experienced depression or OCD and they've responded well to Prozac, it's highly likely that the offspring or that relative will also respond to Prozac. Because ज़रूरी नहीं है कि अगर एक medication काम किए दूसरी भी, but it's highly likely if somebody in the family has experienced depression and has responded well to Prozac, which is fluoxetine, that's the generic name for it. So if they've responded, it's highly likely that the blood relative will also do the same. Aisha.
How likely is it if, for example, a family member has a mental illness, how likely is it for an offspring to have the same? Is it very likely to have?
No.
No.
No. Obviously, when you in comparison to the general population, obviously the prevalence is higher, but it's not something which we call a dominant gene. So it's not like something like Huntington's disease where it's 50% penetration, and if the parent has got it, it will go and it will impact and it will affect. No, it's not that. But however, it does make them more vulnerable. And it's not just what's being experienced at the moment, or some of the things which are coming out, that more than the genetic element to mental illness, environment plays a bigger role. Psychosocial, absolutely. So environment is more important as to the environment that is given. But obviously, with the environment, if you've got a particular gene sequence, you switch it on, obviously, that will be a higher reason for them, or more reason for them to, or make them more vulnerable.
Assalamu alaikum. I'm Uzair Ahmed from Pakistan Television, and first of all, it's very good to listen to you and learn about phobias and manias and disorders and kind of syndromes. I was possibly thinking that this is premature question, but now you have talked about environment, so I need to ask this question: that seasonal affective disorder, which is quite common, and especially once the weather is changing, and in autumn and in winters as well. So how does it affects the proficiency and efficiency of a human being? Because sometimes it results in procrastination, sometimes it gives you anxiety, and till depression there are so many variants. So please enlighten us.
I can touch on it. I won't go into the intricate detail because that will take up too much time. I've got my colleague here, Aisha.
Maybe you can get through your presentation.
Shall I get through? Because I might be able to cover my answers. Aisha is a GP in the UK. She'll probably see lots of seasonal affective disorders. So she'll probably agree. We'll come back to that in a moment, if that's okay. अगर कोई चीज़ मिस होगी ना तो एंड में अगर illness related हो, I'll cover some of them, but if there's anything which doesn't answer the question, then I can cover them at the end. Okay. Those with psychosis have multiple personalities. True or false? You know it, I know. Myth.
How do you define psychosis?
Good question. All right. Good question. Okay, very quickly. First of all, there's no such thing as multiple personality disorder. There's no such thing. Okay, ये एक man-made, sensationalized लफ्ज़ है जो use किया गया है. Previously कभी use करते थे ये. लेकिन there is an element, something which is called personality disorders, जिसमें antisocial personality, emotionally unstable personality, paranoid personality, narcissistic personality, sarcastic personalities वगैरह सब आ जाते हैं.
What about bipolar?
I'll come to bipolar. Bipolar is not a personality disorder. Psychosis. Okay. To answer your question very quickly, I'm talking about mental illnesses are divided into two types. There's psychosis and there's neurosis. Okay? In psychosis, you have illnesses like schizophrenia, schizoaffective disorder, bipolar affective disorder, drug-induced psychosis. Put these aside. Neurosis, depression, anxiety, OCD, PTSD. Okay? So what's the difference between the two? Those who suffer from psychosis lose contact with reality, hearing voices, experiencing delusions. Those have the other ones, hallucinations. And those on the other side, the neurosis, do not. So that's the difference. In psychotic illnesses, people lose contact with reality. And it's a real condition. It's a real condition.
What's the hallucination and affective psychosis?
What is the?
Hallucination and affective psychosis.
Affective.
Oh, okay.
Affective with an A.
Yeah.
Affect means mood. Affective psychosis. नहीं मुझे नहीं समझ आई बात की.
Where do you psychosis is also classified as where provides examiner.
Okay.
Maybe you should
Okay.
finish your
There is affective psychosis. There's not effective. Affect means mood.
How do you justify that?
Affective psychosis. Affective psychosis is that psychosis which has a mood element to it. It's called schizoaffective disorder. But there's no such thing as affective disorder, psychosis. It's the first time I'm hearing that.
But it leads to inability to adjustment and adaptabilities in the societies and variants that are coming out.
No, I've never heard that before. I've never heard that before. Yeah.
Sir, can you please keep the questions for
Keep it to the end? Okay. ठीक साइकोसिस की समझ आ गई ठीक है ना और ये भी पता चल गया कि मल्टीपल पर्सनालिटी डिसऑर्डर इज नॉट साइकोसिस In fact, there's no such thing as multiple personality disorder. ये चीज़ें बनाई हुई हैं. So what I'm trying to do is trying to simplify what actually category mental illnesses क्या हैं. So I just want you to keep in mind कि it's very simple. हम लोगों ने complicate किया हुआ है. बहुत ज़्यादा चीज़ें हम लोग पढ़ते हैं. जैसे इनको आपने पढ़ा कुछ और इसलिए just complicate things. So just keep it simple. Psychosis, neurosis. बाकी उस पर अभी आते हैं. Mood swings, bipolar. ठीक है, mood swings. अगर मैं सुबह उठा मेरा मूड खराब है दोपहर तक ठीक हो गया, bipolar है. Is it? Okay. So it's very important कि यहाँ पे मैं एक और condition है, which we all have right now. अगर मुझे गुस्सा चढ़ेगा, what is गुस्सा? It's an emotion. अगर मुझे खुशी है, what is खुशी? It's an emotion. ठीक है, अगर मुझे jealousy हो रही है, वो क्या है? प्यार हो रहा है, क्या है? These are all emotions. Hate, these are all emotions. And sometimes we mistake emotions for mood. अगर हम खुश हैं, ज़्यादा खुश हैं, वो लोग कहेंगे he's high. अगर अफसुर्दा हैं, sad हैं, we equate sadness with depression. And it's so important not to do so. So we as human beings our day-to-day functioning is dictated by our emotions. And emotions are normal. They are not mental illness. So if somebody is waking up and they have mood swings, गुस्सा चढ़ गया some लोग कहते हैं जिनको bipolar है. Bipolar is a totally different condition. It is a chronic and enduring mental illness. So those who suffer from bipolar, we do not do them any favors. Because it's a chronic and enduring mental illness. We have to remember that. जिसमें mood swings होते हैं और इसमें psychosis भी हो सकता है. That's why I put it in the psychotic category. But mood swings are not bipolar. उसमें mood swings होते हैं लेकिन there's a way of diagnosing them. हमारा problem ये है कि हम लोग diagnose कर देते हैं बैठकर. Isn't it?
But it's normal.
Say again?
But it's normal.
Mood swings can be normal, yeah. Stress means anxiety. Is that true? How many people in this room have experienced stress? How many people in this room have experienced anxiety disorder? So again, remember what we said about disorder, going from the order to the disorder. है ना? Order में क्या था? You can still experience the stress or whatever, or the low mood, or the sadness, but if it's not impacting on your day-to-day functioning on a continuous basis, it is not a disorder. It only goes into disorder category when we experience that on a regular basis and it impacts on our day-to-day functioning. Day-to-day functioning में क्या होता है? ठीक है, हमारा लोगों से मिलना, जॉब पे जाना, खाना खाना, relationships, ठीक है, education. So if there's a prolonged period for about 4 to 6 weeks where it's not going away and you experience them, but अगर वो हो भी रहा है, that doesn't mean you still can categorize it. You have to, a specialist should be able to diagnose that because it comes with other factors. For example, depression. Depression के 3 core features: low mood, consistent tiredness, anhedonia, which is basically a loss of interest in things you previously enjoyed. अगर मैं enjoy करता हूँ, अपना profession enjoy करता हूँ, ठीक है, and suddenly I lose, or over time I lose interest. I don't want to do it anymore, and I feel tired all the time, and my mood is low, and it's consistent on a consistent basis. Then I can start thinking about, hold on a second, this is having an impact on my relationships, on my work, on my finances, etc., on my marital, with my friends, in my work, etc. So it causes issues, it's causing problems, and that's where you may be going across the spectrum from the aspect of order to a disorder. So anxiety disorder is something very different. Stress is different. We all experience stress. Again, let's not, the take-home message here, पिछले 2-3 slides, do not medicalize everything. We very easy medicalize things. Having said that, on the contrary to that, we must also understand what mental illness is because we should not be missing it either. That's very important because we don't do people a favor. जहाँ पे it's like crying wolf, isn't it? कि जहाँ पे पता है ना wolf का, if you cry wolf, sheep वाला जो है, ठीक है, if you do that, then the real thing, then you tend to miss it. You can miss it. And those people who actually really experience it, they can miss it from themselves. We can miss it on them as well. Every negative life event leads to PTSD. True? What does PTSD stand for?
Post-traumatic stress disorder.
And does anyone know what kind of symptoms people experience when they have PTSD? Flashbacks? No hallucinations. Yeah, so the ones are consistent nightmares, flashbacks, hyperarousal states, panic attacks, low mood, exaggerated startled responses related to the trauma, and they have to be present for a consistent period. And it's a real, when people actually experience this, they are real. For example, if they've been involved in a car accident and they consistently, over a period of about 3 to 4 months, it doesn't go away. Because एक चीज़ होती है, when you have a trauma, there's a period of adjustment. ठीक है? और उसको हम adjustment disorder कह सकते हैं. If it goes beyond 6 months, you can diagnose it with something which is called PTSD, which is, for example, an accident, या कोई trauma experience किया, जिसमें flashbacks हो रहे हैं, impact हो रहा है on our day-to-day functioning पे, हमारा distress हो रहा है, anxiety हो रही है, depression हो रहा है, उस चीज़ के बारे में आप सोच रहे हैं, exaggerated, startled responses हो रहे हैं. So that's PTSD, and PTSD doesn't occur every time. Again, it's a word that we generally use on a day-to-day basis. And again, I'm just trying to, I put this up there to debunk that myth. Depression is the same as being sad. We've already covered this. Those that develop a mental illness have to take medication, correct? Yeah. For majority of the people, not always. If someone is experiencing mild depression, they don't have to. We call it watchful waiting. Watchful waiting is very important, and I think I blame us doctors for this, that we are trigger happy to prescribe medication. Wrong thing to do. And unfortunately, we see this in Pakistan. A lot of medication is prescribed very, very easily. There is a period where it's the responsibility of doctor, and again, Aisha will tell you, being a GP in the UK, she will tell you there is a period where you have to wait and do not be trigger happy. It's very, very important. Antidepressants always work. Antidepressants do work. They do work, but they don't always work, because अगर मेरे सर में दर्द हो रही है, मैं पैनाडोल खाता हूँ, पैनाडोल नहीं काम करी, does that mean Panadol as an analgesic doesn't work? No. It's because probably that medication is not for me. I have to probably go to something else like ibuprofen and NSAID or something. Similar with antidepressants, and this is where again people get it wrong. That's why expertise comes into this. We must consult people who are experts in these areas. First of all, do not medicalize. Second, when you want to medicalize it, talk to a specialist. We are very, very quick at self-diagnosing, putting medication and then blaming the problem on the medication, that it's addictive, it's not working. So there is a whole protocol behind how you prescribe medication, if it's to be prescribed in the first place. And no, they are not addictive. Antidepressants are not addictive, and the reason why people call them addictive is because, again, there is a science behind how you prescribe medication. And the way to do it, if somebody's experienced depression for the first time in their life, the way to take an antidepressant is, if you've started the medication on the 1st of January, it takes about 5 or 6 weeks to kick in. It has to reach a steady state in your system. And then people don't know that. And if it doesn't work, they stop taking after 2-3 days. And when they stop taking it, they get withdrawals of the medication. When they get withdrawals, they blame it on the medication and said it didn't work. And because they have withdrawals, they call it addiction. That's not the case. So if they've taken it on the 1st of January and the medication starts kicking in, say by the middle of February, from that date onwards, when people start feeling better, you have to take it for 10 months. If you stop any earlier than that, it's just the way the state works with your neurochemicals in your brain, how they work, the serotonin. You have to, if you go less than that, it's highly likely you will relapse. So there is a protocol and there's a science behind it. And the reason why I'm telling you this is because we prescribe medication, we take medication and we stop medication and we get it all wrong. So there is a way how we should be taking it, and we must consult experts. Will I be on it from life? No. Unless it's a psychotic and a severe and enduring mental illness, like schizophrenia, like bipolar, etc., like schizoaffective disorder, and then medication for the majority of the life, yes, they have to take, like any other medication, like you take if you have high blood pressure, you take it for life. If you have rheumatoid arthritis for the pain, you have to take it. If you have diabetes, you have to take the medication. So these medications, but unfortunately, because of the stigma attached to mental illness, we think of that separately. Think of it as a physical illness, because if you do take it properly, people with these illnesses can lead a normal life. But do we allow them to? They change one's personality. Again, no, it's not true, not correct. Obviously, like anything, people have to make readjustments in their lifestyle. Like any other physical illness, diabetes में करते हैं क्या करना पड़ता है diabetes में? चीनी कम खाओ, diet rearrange करो, walks के लिए जाओ, you know. So similarly, you have to readjust some of the things in your life. And same things with when you do experience certain illnesses, you have to readjust your life. Therapy is about digging up the past, correct? Psychologist? No? No, it's not about digging up the past. There are various types of psychologists. There's supportive therapy, which you can provide by just providing a husband for his wife, or a brother or a parent for their child can provide supportive therapy. It doesn't have to be an expert. So that's the very low level end. It's kind of therapy. You're talking, you're therapy, and you don't even realize it. There's something which we call cognitive behavior therapy. Cognition comes from the word recognition, how we recognize things around us. Behavior. So cognition is how we readjust some of our thought process so that our behavior changes over time. So it is in the here and now. It does dig in the past. So it's in the here and now, what we are doing right now. And this type of therapy where we dig, it's a specific type of therapy called dynamic psychotherapy. And again, the reason why I put this up here is because we actually think that when we talk about therapy, you're going to sit down on a couch, lying down on a couch, the psychiatrist is going to have a pipe in their mouth and talking to you, and they're going to be asking about your bachpan mein kya kiya, ghar chale gaye, chalo ji therapy hogi. That's not how therapy works. And obviously that therapeutic relationship with the therapist is very, very important. You're not put on one part of a conveyor belt, come out the other, and you're fixed. It's a proper process where consciousness, shuru mein jo maine slide dali thi na, about the kya kehte hain, about left to right, wo jo padhna hai, and also about the daughter and the, these are, it talks about things, bringing things to the conscious, and that's the role of a therapist. Where you can think. West में इसको, यहाँ पे भी आपने नाम सुना होगा, West में इसको mindfulness है. And mindfulness is very much in vogue nowadays. Very, very important. Even for those people who do not experience mental health problems, mindfulness is so, so important. If we all manage ourselves daily in a state of mindfulness, we could change a lot of things in our life and our whole thinking process as well. If it didn't work for my friend, it won't work for me, and vice versa. Again, goes back to what I've said. It depends. Every person has their own vulnerabilities, has their own how they interact with other people. Everyone is different. And the last thing you want to do, or anyone wants to do, is do not compare. When someone experiences a certain mental health breakdown, do not compare. On a wider scheme of things, you can signpost and you can say, yes, this is the help we got, maybe this is something you can go down. But to say that they will be treated the same way and they will have the same responses is absolutely wrong. Okay? A lot of people ask this question, is mental illness because of bad parenting? No, it is not because of bad parenting. Okay? Again, it's a misnomer, it's a myth. However, upbringing does contribute. It does contribute towards certain mental health conditions, not necessarily mental illnesses, but it can have an impact amongst lots of other things. Previous history, genetic makeup, vulnerability, stress, etc. Mental health, culture and religious beliefs. What's the mix? Does our cultural and religious beliefs have an impact on mental health?
To a larger extent.
Yes? Everywhere. I used to live in the Republic of Ireland. And
is that the secular faith is at the top.
Yeah.
Faith is secular would not affect.
Yeah. Correct. Absolutely. In the West, we borrow a biopsychosocial model of managing illnesses. Bio, the biological, chemicals, etc., medication. Psychological, which is therapy, etc. Social, that is our environment and how we readjust ourselves to all these three things. For me, the most powerful is the psychosocial. Very, very powerful. If we can get that right, we won't need the biological. We can move away from the biological for majority of the mental illnesses. But yes, culture does have an impact. We did a study a few years ago of beliefs about jinn, black magic, evil eye amongst Muslims, age, gender, first language. So this is something that we published a few years ago. The reason for that is because when I was working in forensic psychiatry, my consultant, supervising consultant, asked me कि शायद जब भी मैं prison में एक Muslim prisoner को देखता हूँ हमेशा कहता है मुझे जिन चमड़ गया था इसलिए मैं नहीं किया था. So they committed a crime क्योंकि जिन चमड़ गया था या किसी ने मेरे पे नज़र डाली है या किसी ने क्या कहते हैं जादू किया मेरे पे. कहते हैं and he didn't understand that concept. हमें तो समझ आती है ठीक है, we can laugh about it. But usko bilkul sahi. And I told him, being from a obviously cultural background and a religious background, we understood these concepts. But they did not. It was alien to them. And he said, wow, how fascinating is this? And he asked us, and it's Tim Hardy was his name, he said, let's do a study. So we just did a qualitative study and asked lots of, formulated a semi-structured, piloted a questionnaire and then sent it out to lots of people, got good responses back. And we asked, one of the questions we asked is, what is mental illness caused by? And look, this is the response we got back. 80% said it's because of jinn. 60% said it was because people were possessed. 65% said it was due to black magic. And 73.8% it was due to evil eye. Now, okay. No, this is in the UK. Say again? Yes, Asians, of course. No. So this was not necessarily just Pakistanis. These were in Muslims. So especially, Asian Muslims. Yeah. So the reason why I put this up is because you see how very easily we move away from some of the understanding of what mental illness may be, and actually what our mindset is. So that's why I put up, does culture and religion have an impact on how we function? Now, I'm not saying for a minute that meditation, spiritualism, or religious inclination doesn't. There are certain things we call positive prognostic indicators. Okay? With every illness, what is the prognosis? Prognosis. And I think one of the things which is really important and something that we encourage and something the Royal College is taking up is moving from the biopsychosocial and adding the third element of spiritual. Because for majority of the people it's important. And if something is important for someone, why are we missing it? You see? Provided it's done sensibly. And it's our role to put some of this understanding and debunk some of the myths around it. But for many people, reading namaz, reading the Quran is important. It makes them feel better. Fine. As long as it's not harming anybody. Yeah. So some of the people said, okay, would you go to a psychiatrist? No, I wouldn't. Why wouldn't you go? Because they would think I'm superstitious. They would misunderstand me. They would think I'm backward. There would be language barriers. I would feel embarrassed. So you see, this is the stigma related to the mental illness itself. This is some of the things which people talk about as to why they would not go. And imagine the number of people who we miss who have mental illnesses. So there is something which we call a DUP, which is the duration of unmedicated, untreated psychosis. And like anything else, or majority of illnesses, physical health, the longer you leave it, the more difficult it is to treat. So it's very important for people like us, like psychologists, those from health backgrounds, to help to educate people, to bring about the awareness, to debunk the stigma element of it. So lastly, I just want to touch on this. This is a concept which is being advertised, being used all over the UK, and it's absolutely fine. I'm a big fan of social prescribing. And social prescribing basically talks about the things that we should be doing on a day-to-day basis. Positive things, work, relationships, hobbies, interests. And the easiest way you can all relate to that, what happened during COVID? We were all locked up. और सबने क्या कहा था कि what should you be doing during COVID? खाना ठीक रखें, पानी पिएं, नींद ठीक रखें, hobbies रखें, ठीक है, relationships, communication, contact रखें लोगों के साथ, because you start the whole element of isolation, the impact that it will have on people. That is social prescribing. But social prescribing is not just for COVID. Social prescribing is for us. And to manage ourselves on a day-to-day basis positively. It's so important that we have something to look forward to. We have a structure to our day. If you wake up and have nothing to do, you are a recipe for disaster. Because as they say, an idle mind is a devil's workshop. Okay, so it's very, very important that we have a structure, we have a vision, we have something. And that doesn't mean you fill up your day. Work, rest and play, and how you proportion that throughout your day is very, very important. I could go on about social prescribing because it is a science within itself, and this is something which we are bringing into community mental health teams in the UK and many of the Western countries as well. In Pakistan, despite me touching on some of the negative things, the good thing about Pakistan is for now anyway, it's a communal-based country. People live like this, sometimes too much. So it's community-based, and that is very positive. In the UK, as many of you have been in the UK, and you look at some of the people from the elderly population, they're living alone, most of them, because the concept over there is once the kids fly out of the nest, they're gone. They are gone. And imagine the pressure on the child when they know that when you turn 18, you're adult, you're not supposed to. Imagine the pressure on the child. Okay? But also imagine on the parents when they also now feel that they're gone and there's no expectations, and that's why there's a lot of isolation, especially coming back to one of the questions regarding to SAD, the seasonal affective disorder, the combination of being isolated, the dark. If you understand the processing of serotonin and how it works, the light, the daylight is supposed to come into your eyes, and here goes to your retina, a certain part of your brain, and it triggers certain receptors, and it manufactures serotonin. That's the reason why seasonal affective disorder occurs, because daylight is less, and sunlight is less, but there is also another one, that when you have too much in the summer, it's called the manic switch. That rather than having the depression around about October, November time, come July, in hot climes especially, you can have something which is called the manic switch. That is that you get too much, and that's maybe imbalance goes the other way. It's very rare, but I'm just throwing it in there as you asked the question. Okay, one last slide. What is this? It is an X-ray, yeah. The reason why I put this up here is because who's heard of the term having butterflies in the stomach? Yeah, what does that actually mean? Happy. Not happy. Anxiety? Yeah? Okay. Now this is, although I just Googled this and found this and put it here. The reason why I put this here because something happened in real life, because when I started as an SHO, there was another doctor who came from another part of the country. I won't say from where. And the consultant was asking during the ward round, can you give me the presentation? And they said, well, I think this patient's suffering from a delusion and therefore schizophrenia because they believe that they have butterflies in their stomach. So you can see, you can think it as concrete thought, somebody who does not know the concept of something that you use in the West. After all, the world is global now, so everybody knows what these terms mean. But for this particular doctor, who came from another part of the world, had never heard of the term. So for that person, rather than having the abstract thought, which probably they do have, in this particular case, their thought was very concrete. And they thought, because this person is saying that they've got butterflies in their stomach, that means they're deluded. And if they're deluded, that means they're psychotic. If they're psychotic, that means that one of the differential diagnoses is schizophrenia. So I just wanted to put that up there, how very, very easily, if we do not understand, how we can very, very easily get the very, very basic things which we may take for granted like this. For some people, they may have never heard of it. So, open for questions. Thank you.
Can I ask?
Of course, yes, I think there's two questions.
Excellent, exceptional. Dr. Sir?
Who's going first? Okay.
Exceptional. Just two quick questions.
Yeah.
Pardon me, I might be the guy asking most of the questions. So one question is regarding the therapies, right? So you have Viktor Frankl who stated logotherapy and then the existentialism concept. Is that prevalent? Because if that is, then the value chain and propositions and the meaning that you have in life, that's a question. How is that integrated? Because when you meet a person, you don't know what kind of therapy will work, just like the drug. So you would have to make a best call at it. So the question really is, do you do that? Or is it a pre-prescribed thing? The second question is, certain kind of ailments are actually silent killers. Depression, suicide, right? So majority of the things is people aren't trained to look at that in the society, in their kids and their mothers and their fathers. So what do you do in training people who, I mean, instead of finding out the symptoms very late in the game, how do you prescribe the awareness perspective? These are my two questions.
Okay. My simple question, that I keep it simple. Why are we complicating things? Now, these terms that you have mentioned in therapy, they may sound very sexy. They may sound as if they're going to change someone's life, but are they actually? And how many people's lives have they changed? You see, by these terms, when we come up with these terms, I mean, these for a certain level of complexities, we can do that. But you have to start at a basic level. We can't sit with a person for 3 hours and say, you know what, you need this XYZ therapy, which is only available in Exeter, they've got a 3-year waiting list. You see? And some of these therapies that you mentioned, it's hardly you will get them anywhere in the UK. You'll have to probably go to a private, and even then you'll have to wait about 2 years. Who wants to wait 2 years? You see? Start basic. Most of the things in life, and this is again, I would urge, let's not complicate things. Keep them nice and simple, because the majority of the things in life are simple. If we are looking at certain forms of therapy for people, and people are looking, start from the basics. And if they don't work, go to the next stage, go to the next level. And they're still not working. If they are not working, one needs to ask the question, why are they not working? Is it because of the therapy? Is it because of the therapist? Or is it because of some resistance going on with the person? That's the responsibility of the therapist. Because in majority of the cases, when therapy does not work, majority of the cases is resistance from the individual, not because of the therapy. And one needs to understand, and that's the role. And that's why I say keep it simple. It is the role of the therapist to identify the resistance and relay back. At the end of the day, remember one thing, at the end of the day, remember, the buck always stops with the individual. As a professional, your responsibility is give the information back. It's the responsibility of the person if they want to take it on board, because the majority of the cases, people do not want to hear. I'll take, for example, people with very mild, and we all have different forms. Myself, I will have some elements of narcissism in me. I will have some elements of paranoia in me. I will have some elements of antisocial elements in me, and all the other personality disorders that we call. But they're at a level, which are at a very low level, which I'm able to navigate, and I don't allow it to impact on myself or other people. But when it starts impacting on other people, that's when it becomes a problem. When the very definition of personality disorder is the deeply ingrained maladaptive pattern of behavior which impacts on the person and those around them on a continuum, on a continuous basis. So similarly with these, so if the person is not responding, it is the role of the therapist to understand why and relay that information and leave it as that. And leave it as that. It is then the responsible person. And the reason why I brought up the personality into it, because people have their guards up. They might think they're there in person, but majority of the people, I remember many of time in my outpatient clinics, I used to have patients referred to me from our GP colleagues saying that they suffer from resistant depression. And we've tried all forms of antidepressants. We've just tried A, we've tried B, C, and it's not working. We're referring to the specialist. So they come to us and we realize, and many times it's come that, patients have their guard up. And they have their guards around them and they do not want that guard to be lowered because they will be exposed. Their inner traumas will be exposed. And many times what we've done is we've actually had to diagnose them with some level of narcissism. And when their guard is dropped, when you're able to penetrate some of the elements, the giveaway of someone with narcissism, they will disappear. They will not come back again. So it's understanding. So it's not about the complexity. Keep it nice and simple. That's the answer. And there are, yes, certain silent killers. And silent killers, if depression, when you say silent killers, when they talk about, I remember when I was doing medicine, the big five, cardiovascular problems, diabetes, there was a few others, high cholesterol levels. We used to call them the big five. There was 2 more, can't remember. I think depression, obviously, it's one of the killers. I think after cardiovascular MIs, I think the biggest is suicide.
सर 2-3 क्वेश्चंस हैं. नंबर 1, पहले तो मैं सर इंग्लिश में नहीं बात कर सकता अगर इट्स कंफर्टेबल फॉर
पंजाबी में बात करना.
ठीक है. एक तो ये कि सर ड्यूरिंग थेरेपी प्राइवेसी कितनी मैटर करती है, नंबर 1. क्योंकि इफ़ देयर इज़ अ पर्सन हु गॉट रेप्ड इन एनी एज ऑफ हिज लाइफ, तो उसके लिए सबसे बड़ा प्रॉब्लम यही है कि मैं अपने थेरेपिस्ट को या जिसको भी मैं ये बात बता रहा हूँ, ये कॉन्फिडेंशियल रहे उसके और मेरे दरमियान.
Actually, that may be a very लोग ये समझ रहे हैं कि स्ट्रेट फॉरवर्ड आंसर है इसका, लेकिन एक्चुअली इट्स अ वेरी गुड क्वेश्चन. It is responsibility of the therapist to maintain confidentiality, the privacy. However, there is a very famous case called the Tarasov's case. And in the Tarasov's case, there was an American, a chap called Tarasov. तो उसका केस ये था कि during the process of therapy, he had told his therapist that he's going to go and murder his wife. So privacy or confidentiality होनी चाहिए या नहीं होनी चाहिए? Or should that case be reported?
एंड सेकेंडली सर, मैं पाकिस्तान के पर्सपेक्टिव में थोड़ी सी ये क्वेश्चन करना चाहूँगा, क्योंकि यहाँ पे एजुकेशन सिस्टम बहुत तबाह हाल है एट गवर्नमेंट लेवल. तो बच्चों को बेसिकली एट चाइल्डहुड इस बात का पता ही नहीं होता कि हमने क्या करना है. ना तो यहाँ पे टीचर उस तरह के ट्रेंड हैं कि कोई प्यार से बात कर सकें या उन्हें कुछ बता सकें, ना उन्हें ये पता होता कि हमने कैरियर कौन सा चूज़ करना है. बस किसी से सुना, इधर से सुना, बस यार इसमें चले जाओ, डॉक्टर बन जाओ, इंजीनियर बन जाओ, साइंटिस्ट बन जाओ, ऐसे कर लो ऐसे कर लो. तो वो उनके लिए फिर आगे जाके उनको पता लगता है कि नहीं. तो इज़ इट के आपके स्कूल लेवल में भी को मेंटल अवेयरनेस होनी चाहिए, बच्चों को पता होना चाहिए कि ये
As our public health colleagues will tell, prevention. ठीक है ना. हम लोग तो क्योर के जब ट्रीटमेंट और क्योर पे जाते हैं ना, there is a step before that and it's called prevention. तो ये सिर्फ पाकिस्तान का मसला नहीं है. This is not confined to Pakistan. Obviously पाकिस्तान में it's हमें ज़्यादा नज़र आता है. UK के schools में भी there's a lot of issues, lot of drug problems, lot of parenting issues, lot of child issues, lot of peer pressure, social media के impact. So there are a lot of things. We do this on a regular basis. We, as part of our role through the Royal College of Psychiatrists, we do reach out to schools and universities, etc. So that is more the public mental health, as we call them, preventative.
I have two questions. First, has the use of electroconvulsive therapy totally disappeared, or is it still used in certain situations?
ECT is still very much used. It is still very much used. I think there is a lot of controversy around ECT. ECT is used for interactable, very severe depression. If you look at the way ECT is used in Pakistan, it's shameful. Not only because of the indications it's used for, but also how it's used as well. It's horrible. पहले से कम होगी हुई है, and the reason कम होगी हुई है is because there are other more safer with less side effects treatments that have come out. One of the prevalent one is which we call RTMS, repeated transmagnetic stimulation, जिसमें you do not have to go under general anesthesia, and you don't get those electrodes on your temples. Electromagnetic transcultural stimulation is basically some magnetic which you put here, and you just sit there, you're awake, nothing happens, there's no side effects, no impact on any of your day-to-day functioning, and because of the use of transmagnetic stimulation, TMS, ECT की usage कम होगी हुई है. लेकिन I think the important thing here to say is ECT is effective provided it is used the right way within safe environments, and also within for the right people, and also keeping in mind, because one of the things that ECT does cause is memory problems for patients. So we have to make sure, number one, that the patient is not vulnerable to that, and number two, we also have to assure that after giving one application, the assessment is there. Unfortunately, वो होता नहीं सही तरह से, and that's why some of the problems which are associated with ECT, they occur. So not as much as before, but yes, it's still used.
My second question is, please give us an idea of the range of drugs that are available to the therapist today in these times. Are there 15, 20, 30, what? How many are they? And do they all target the synapses?
Yeah.
Or is there some other part of the neurosystem that they act upon?
Let's go backwards. So majority of the drugs, yes, they are working on the receptor level, on the neurochemical level, mostly between the synapses, जो nerves की जो होती है, pre-synapse and post-synapse. So it's mostly, that's the area where they work. Unfortunately, because of psychiatry being a Cinderella speciality, there's not a lot of money and funds that goes into research, unfortunately. And for that reason, जिसे हम दूसरी बीमारियों की diabetes, cardiovascular, serious cardiovascular problems का जितनी research होती है, जितनी नई medication आती है, psychiatry में unfortunately we just have a handful of medications. It's very, very slow. However, the medications that are coming out are better than their predecessors. For example, if you look at some of the antidepressants that were used 50, 60 years ago, like tricyclic antidepressants, you know, they were toxic on the heart. Any person who took an overdose inevitably would die. And just imagine someone who is suffering from depression and you're giving them something if they take it as an overdose, and if they have suicidal, if they take it, it's highly likely they will die or they will succumb in some shape or form to that. As time has progressed, we have the newer form of antidepressants called serotonin selective reuptake inhibitors, SSRIs, जैसे Prozac है, fluoxetine हो गया, citalopram वगैरह. They're slightly better. They are not toxic in overdoses. And then we have subsequent medications. The most recent one, antidepressant, is something which we call vortioxetine. Its mechanism of action is slightly different from the other ones, as is serotonin 2 tricyclics. And also it is known, although it's still early days, to enhance cognitive function as well. The same is the case with antipsychotics as well and mood stabilizers. Antipsychotics, some of you may know, like risperidone and olanzapine. Unfortunately, the downside of antipsychotics is that they have horrible side effects. Just like Parkinson drugs. If you give Parkinson drugs to individuals, it may settle their very severe interactable tremors. It may improve their gait slightly. But unfortunately, it comes with horrible side effects like hallucinations, etc. And lots of others, if you read up on them, lot of others. So there are certain illnesses, certain diseases where you have a lot of research going on. Unfortunately, in the world of psychiatry, we need much more. And that's why we have to be even more careful how we prescribe the medication. Very, very important. Medication, just psychiatric medication, it works. It works, and we have to give it when we have to give it. The problem is that we give it to the wrong people and we prescribe it the wrong way and we stop it the wrong way, we increase it the wrong way, etc. But unfortunately, Pakistan mein jo practice jo main dekhta hu, it is horrible. And the cocktail of medications, do antipsychotic, do antidepressants, mood stabilizers, Xanax pe dala hua hai, it's not good. And when we do, I mean, UK se hum aate hain, log पूछते हैं, combination inevitable होता है, Xanax का एक होता है, दो antidepressants होते हैं, एक antipsychotic, antipsychosis है ही नहीं, antipsychotic दिया होता है. क्यों दिया होता है कि mood stabilization के लिए? So you're going to zonk out the patient, जो functioning जो expect करते हैं, and there's no concept here, unfortunately, of the psychosocial element towards treatment. This is something that we only a few weeks ago, the President Arif Ali, because of our links through the previous government and subsequently now, we are assisting them with mental health policy. I don't know how far it's going to go, to be quite honest, because some of my previous experiences having worked, but so I'm not going to hold my breath on that one. But they've asked, and you know, the social aspects of psychiatry, I think it's so important. And this, you know, this work that you're doing is absolutely phenomenal. You know, this whole concept of the black hole and how we bring about awareness. We need more of this. And we may not know it, but you know, a lot of people may actually benefit for their own mental health through you know, these initiatives.
Sure.
Any other questions? Okay, sorry. Go.
Sorry. So I wanted to respond. आपने जो सवाल किया था कि इस कंट्री में इतनी अवेयरनेस नहीं है सब कुछ. एक उधर इंग्लैंड में इसको इस तरीके से फ्रेम कर रहे हैं कि हेल्थ प्रमोशन की तौर पे, तो मेंटल वेल बीइंग का कॉन्सेप्ट काफ़ी वहाँ पॉपुलर हो गया. वहाँ पे जो हमारी रॉयल फैमिली है, प्रिंस विलियम और हैरी, और उन सब ने इसके ऊपर काफ़ी टॉक्स किए हैं, अवेयरनेस रेस किया. तो एक तो मेंटल वेल बीइंग बहुत ज़रूरी चीज़ है, बच्चों को स्कूल की उम्र से सिखाते हैं. दूसरा एक कॉन्सेप्ट है जो कि काफ़ी इंस्टीट्यूशंस ने दुनिया में बोरो किया है यूके से, इट्स कॉल्ड द मेंटल हेल्थ फर्स्ट एड ट्रेनिंग. एंड उसमें जैसे हमारे काम पे वी आर बाउंड टू हैव एट लीस्ट 2 or 3 मेंटल हेल्थ फर्स्ट एड ट्रेनर्स इन आवर ऑफिस in each department, in each school, in each institution, in each corporation. So they can watch out for signs इनके colleagues में कि मुझे कुछ ठीक नहीं लग रहा. सेफ गार्डिंग का भी हम करते हैं कि अच्छा इधर कुछ सही नहीं है, हम किसको रिपोर्ट कर सकते हैं. तो टाइम लगेगा, लेकिन दीज आर इंटरेस्टिंग कॉन्सेप्ट्स जो पाकिस्तान में हम इनके बारे में सोच सकते हैं.
Oh, sorry, beg your pardon.
As far as you can say all this given away the lecture, diagnosing and medication, it's your sports and you are well adept in it. But as far as I am concerned, to give up opinion, there is, if you study Bertrand Russell, he wrote a book, Conquest of Happiness, in which one of the leading chapter is there. He talks about a Byron poet, and at the end of he said that Byron was a poet, and he, you can say, gave the idea of Byronic unhappiness. Byronic unhappiness, you can say, came to appearance when a person goes around the world, see all the scenes and scenarios and the fascinating areas and beauties and aesthetic senses, the fulfilling there. Along with he, you can say, eats all kinds of foods. And these two things, when comes to ending, at the end, he gives opinion, there is nothing under the sun. And where onward, he becomes a psychotic or somewhat, you can say, psychological, comes on the surface. The main thing is that when the societies... I'm coming to that question. I'm preparing the pitch for it. England-like or the Western-like, they are very organized. Each and everything like education, jobs, and life is ready and just to be eaten and rise on the life. So there is no suffering or struggle to economy or to some things, which after that, when they are, you can say, dished with and equipped with all kinds of facilitation, there is no missing in their lives. So altruistic, you can say, points are not there. If you have a cause in your life and share your assets like education and your wealth, I came to conclusion such kind of people who are dedicated to humanity, they have no such kind of suffering. And faith is the second. And psychology elements comes when they deprive of something all of a sudden, then they start having stress and such and suffering. Anyway, it's a complex kind of thing.
Thank you.
फ्रंट से काफ़ी हो गई, बैक से समझ आएगी.
Whatever rocks anybody's boat. इधर क्वेश्चन था, इनका था एक क्वेश्चन. अच्छा चलें.
I'll be quick. So आप बाहर UK में होते हैं तो आपका एक outsiders मतलब आप observe कर सकते हैं पाकिस्तान को, you know, bit from the outside. तो क्या वजह है कि हमारी सोसाइटी में मेंटल हेल्थ के ख़िलाफ़ अभी भी एक बायस, एक स्टिग्मा है, और पिछले अगर जैसे 20 साल में देख लें तो इम्प्रूवमेंट काफ़ी कम हुई है, और क्या आप ऑब्स्टिकल्स देखते हैं जिसकी वजह से ये है, और क्या साइंस ऑफ होप आप देखते हैं कि ये चीज़ बेहतर होगी?
Good question. Hopelessness is a sin. One should never be hopeless. ठीक है ना, there's one should keep going. मैंने जब ग्रेजुएट किया था रावलपिंडी मेडिकल कॉलेज से, यूनिवर्सिटी नाउ, तो हमारा जो प्रोफेशन था, जो साइकाइट्री, बिहेवियरल साइंसेस, ठीक है, इट वाज शन्ड अपॉन. छोटा सा डिपार्टमेंट था, कोई जाता नहीं था, लेक्चर्स बंक करते, कोई नहीं जाता था. And now I go and look at it, it's marvelous, it's brilliant. एक पूरा एक सेंटर खुला हुआ है, and it's the same is the case in other universities. तो मुझे regularly, अगर खुद, whenever I come in person, I'm always asked to come and deliver, not only there, कराची में भी, लाहौर वगैरह में भी, UK में बैठ के वहाँ से लोग invite करते हैं. So this was never the case before, never the case. So I wouldn't say things haven't progressed in Pakistan. Things have progressed. There are other things which come to the fore, लेकिन awareness है. I've had an opportunity to go to a lot of countries, and one of the two most intelligent and switched on people that I've seen, this isn't just my view, मेरी अपनी views हैं. One is the Turkish, they're very switched on, and one are Pakistanis. And I kid you not, हमारे में potential बहुत ज़्यादा है, a lot of potential. I come in, we look at the youngsters in awe. Every time I come back to Islamabad, we look at the creativeness of people. Oh, कितना potential है लोगों में. So I don't think कि यहाँ पे लोगों में कोई urge नहीं है. There is an urge there, but I think given the right environment, and I think वो environment create करने की बात है. जैसे ये है, ठीक है ना? This all. I think you have to give the right environment to the people, and I think if that right environment is given to Pakistanis with guidance, a bit of guidance and signposting, I think we could go places. We could go places. Like in जो stumbling block है ना, वो it is not the potential. The stumbling block is the environment of the structures, systems and processes. That's my view. That's my observation.
3 snap questions. Snap questions.
Snap questions. Okay.
Is autism a disorder or an illness?
Shall I answer that one quickly? Okay. It's a neurodevelopmental condition. Okay. Which is different from a mental illness. It's not a mental illness.
Right. Yeah. Secondly, at what level is mental in a person legally insane?
Okay.
I'm a lawyer, that's why I'm asking. At what level of whatever you explain is a person legally insane?
Yeah, keep the mic on.
At what level is he legally insane? And the third question is, what is the Cinderella concept of psychiatry?
Okay, I'll go to the Cinderella one, that's easy. Cinderella इसलिए because Cinderella is somebody who was shunned, not looked upon, उसको ज़्यादा लिफ्ट नहीं कराई जाती थी. इसी तरह psychiatry को भी, not just in Pakistan but UK में भी, अगर funding देखें, बड़ी कम, even जो health की जो fund आती है, उसमें minuscule amount उसको ring fence कर funding आती है, जिसमें research भी और service delivery भी. So that's why I called it a Cinderella. A lot of people call it a Cinderella speciality because of that. It's getting better with time. COVID helped because mental health came to the fore all of a sudden. और बीच में आपका question था about
Legally insane.
Legally insane. Very good question. Legally insane. Okay, so if somebody is standing up in court and I was asked to come in as an expert witness, okay, now first of all, obviously, if somebody has committed a crime under the influence of drugs and alcohol, it is not a defense because it's something which they have self-induced. Okay, so that's the first one. Okay. एक मिनट. दूसरा ये है कि this concept, you'll be very interested, goes back about 1200 years, and it's a concept which the West has adopted. It was written by, at that time, जो भी Iraq में, I've forgotten the name of the author. He had written a book about insanity, jurisprudence of insanity. I've forgotten the name, मुझे नाम उसका भूल गया बंदे का. So it's what is used in UK courts at the moment. कि a person will be guilty of what they've done unless they come under 3 categories. One, if they're a minor. Number 2, if they're asleep, ये उस वक्त लफ्ज़ nowadays called automatism. Epilepsy में, in between epilepsy जो fits वगैरह होते हैं ना, there is a period where people lose contact with reality. ठीक है, जिसमें automatisms कहते हैं उनको. ठीक है, so they've said where a person is asleep, जिसमें sleepwalking भी कह सकते हैं. And the third one is क्या कहते हैं, जनून उस ज़माने में कहा. This is psychosis. So if a person is a minor, at a certain age, whatever you consider, in UK after the age of 16, someone can be committed. Before that, they can't. एक चीज़ होती है जिसको Bolam test कहते हैं, between the age of 16 and 18, वो test के through जाना होता है कि are they mature enough. और दूसरी चीज़ होती है psychosis, और तीसरी चीज़ automatism. So these are the 3 categories under which a person can be considered fit to plead and fit to stand trial and can be. Like in a situation where if somebody has committed a crime but it's under the auspice of a mental illness, then obviously they will still have to spend the time, but that time is a diversion to a mental hospital for treatment. Someone with, and this is more for psychosis. The other shuru mein maine kaha tha, mental illness 2 types, neurosis, psychosis. So they have to have lost contact with reality.
And it's not you can no noise, right cooking and lunatics.
Yeah.
We had a session over here a few months back, and they talked about the connection between the mind and the gut. So is it possible that certain foods can exacerbate a mental illness? Not just alcohol and drugs, obviously they can, but even regular stuff like sugar or other stuff, and vice versa. Can mental illness sort of affect your physical health? And secondly, about regulatory issues in Pakistan. Psychiatry is regulated by the Medical and Dental Association. Should there be a separate body for it that should also regulate other sort of counseling and other mental health related therapies and counseling and psychotherapy? Should there be a separate body for that?
First one, gut and health. Really good, one of my favorite topics, because there's a lot of work going on at the moment in places like Harvard and Oxbridge at the moment. And at the moment, there is an association. There is not a cause, there is an association between food and mental illness. As a what you eat is what you are. The interesting part is, serotonin ka naam suna hua hai? Kya hota hai serotonin? Happy? Where is it manufactured? 80% of it is manufactured in the gut wall. Interesting, isn't it? So the theory at the moment, and it's just a theory because it's not saying that it is a cause, they're saying it can be associated with it, is that the kind of food that you eat has an impact on how the serotonin is manufactured further and released in the body. So there's a lot of work going on. So aapka jo fauna and flora jo hai aapka gut ka, and some of the things which like kya kehte isko? Probiotics, kafir. These are supposed to be really good, and there's some weak studies which actually say they actually improve your mood, probiotics, because of how they manage some of the flora and fauna within your gut wall. But again, it's very early days at the moment. There's a lot of work that is going on between nutritionists and psychiatrists at the moment, where they are working together and in collaboration, doing some of the work to understand and to do some of the studies as to how people actually feel. There could be a lot of placebo effect as well, but at the moment there's a lot of work going on. It's still early days, so I can't give you a definitive answer. Like so far, it's saying that there is definitely an association. So दूसरी बात आपने पूछी है, PMDC, Pakistan Medical Dental Council, obviously they all come under doctors. जो psychologists हैं, they have nothing to do with PMDC. They are totally different. So under PMDC, it's just Pakistan Medical and Dental Dentists and medical doctors, including psychiatrists. So yes, I mean, they're regulated by them. बाहर के भी मुल्कों में GMC हमारा General Medical Council, so we are regulated by them, we are monitored, and all our appraisals and revalidation are conducted through them, as long as it's done properly. अगर आप psychologists की उनका एक अलग governing bodies, I don't know what is in Pakistan, though in the UK में इसको मेरे ख्याल BPAP कहते हैं, British Psychological Association, something like that. उनका different governing body है.
So a quick question from my side. This has come from a day-to-day, discussions that we have on the floors with the corporate entities and all. So we were sitting together yesterday and we talked about the bipolar people that we, get to see in the office every now and then. And fortunately or unfortunately, they have reached a ladder up high. So we have to deal with them. So just to put the things in perspective.
Sorry, people with bipolar are in senior positions, you're saying?
Basically, that's what people tell. Okay. To each other that this person is bipolar, but he's become XCXO or whatever. So just to see things in perspective, what are the motive things to know this person can be a bipolar categorized, and how to deal with that person if he surprisingly reaches to a ladder that he's difficult to deal with?
Okay. I think the first thing you must do is start calling them bipolar. Because it's very unfair if people who have a diagnosis of bipolar affective disorder. It's very unfair. Because bipolar affective disorder is a real illness, and they're not the kind of people who are nasty, who will pull other people's leg and get up there, because probably that's what you say. Irritable honge, mood kharab hoga, sadiyal honge, pahunch jayenge upar. I can give you my understanding behind how some people get there. And a lot of people, they say, who are in senior positions, in very, very high positions, a lot of them describe them as sociopaths. And I'm not surprised sometimes, because it depends. Sometimes you have to be ruthless. Sometimes you have to be ruthless to get up there. Is it a right thing to do? I don't think it is. People who are good, who are honest, who do it the right way, also get up there. But other people, the giveaway is people who are sociopaths can only thrive in chaotic environments. So if you are in a chaotic environment and a person has reached the ladder up there, then obviously there is something wrong within the organization where someone is like that has been allowed to do that. And that particular person, the way their dynamics and they work is they thrive on chaos around them. So they make sure that there is chaos around them so they can thrive. So the attention and the spotlight is not on them. Does that remind you of a lot of politicians? Anyway, leave politics out of it. I would not categorize them as bipolar. Again, I think आप देर से आई थी तो वो बात ही थी कि हम लोग बड़ी easily words like OCD, PTSD, वो the depressed है, वो the OCD है, वो the bipolar हम बहुत आसानी से use कर लेते हैं. Just as so we must not call them bipolar. You can call them something else.
अगर हमने किसी बंदे को देखना है, because in Pakistan we don't tend to go to the psychiatrists or even talk about our mental illness. It's embarrassment, of course, or maybe we don't think that we're mentally ill at all. So how can we say कि ये symptoms इस बंदे के हैं जो कि इसको bipolar बना सकता है या can be termed as a bipolar person? Or so this is what I wanted to know कि what is bipolar actually?
Okay, I can tell you what bipolar is. लेकिन याद रखें जिस तरह mental illness है ना उसी तरह someone like yourself who is not a doctor, obviously इस तरह अगर आपको कहें कि आप बताएं कि आप rheumatoid arthritis को कैसे आपको पता होगा, कोई इस तरह होके चल रहा है, how would you know? You wouldn't know. ठीक है ना? उसी तरह अगर कोई किसी को पेट में दर्द हो रही है आपको क्या पता होगा कि इसको गैस्ट्रोएंटेराइटिस है, इसको क्रॉन्स डिजीज़ है, इसको कार्सिनोमा है, आपको नहीं पता होगा. Yeah. So उसी तरह any kind of illnesses. लेकिन why do we then attach a label to a mental illness? The good thing is if you want to know about it, we can certainly have a discussion. Someone with bipolar has when depression kicks in, and the depression lasts for approximately the same period as depression does. But after the depressive period, they could have a high. And a high doesn't actually mean that they are happy. A high means they are very happy and they partake in a lot of inappropriate activities, too much spending, they're wearing clothes which they would not normally wear, maybe very colorful clothes. It's a female, doing things out of character, getting involved in relationship, being disinhibited, spending endless money. अगर बैंक में 10,000 pounds पड़ा हुआ है, वो 50,000 pounds की गाड़ी जाके खरीद लेंगे. You see, so there are out of character behavior which is called hypomania or mania. We'll send them. So it's not someone who talks and is being nasty or irritable, although irritability can be part of mania. But it's someone who's irritable, who's being nasty, angry, गुस्सा अपना काम निकाल रहे हैं. That is not bipolar. That is not high. Okay, so that's one of the things. But we can discuss what individual diagnostic criteria are. Does that answer your question?
डॉक्टर साहब एक तरह हम एक कॉमन बंदे के तौर पे तो हम ये समझते हैं कि कोई मेंटली बड़ा कमज़ोर हो तो फिर वो किसी हिसाब किताब वाले के पास जाता है, लेकिन ये पूरी दुनिया में ही है कि किसी वो पीर के पास जाना या नजूमी के पास जाना, या मतलब वो इंडिया में जिस तरह वो योगी या जोगी उनके होते हैं, तो कॉमन एक बंदे के तौर पे तो भाई ये बंदा समझता है कि ये सारी माइंड गेम है. आप यानी अपने इल्म के हिसाब से इसको किस तरह डिफ़ाइन करेंगे? बाज़ औक़ात वो बिल्कुल ठीक भी बातें करते हैं तीर तुका, तो मेरे ख्याल में तो ये एक वो एनालिसिस करके ही कोई हिसाब किताब लगे. जैसे हम कुछ लोगों का, किसी ख़ास एरिए के लोगों का, किसी ख़ास नस्ल के लोगों का एक उनको कुछ ऐसे टेबल बनाएं तो कुछ चीज़ों का हमें पता चल जाता है कि, या बाज़ औक़ात गुफ्तगू में भी हमें पता चल जाता है ये अगला बंदा ये बात अब करेगा. तो मतलब आप इसको साइंस की, मतलब साइंस तो इन सारे अलूम को नहीं मानती, लेकिन अखबारों में भी रोज़ छपा होता है, अंग्रेज़ी भी, उर्दू भी, सारी दुनिया में. तो इसको ज़रा काइंडली थोड़ा सा एक्सप्लेन करें. दूसरा एक मेरा सवाल ये है कि बाज़ औक़ात ये है कि हम अपनी फ़िटनेस के हिसाब से बड़ा थोड़ा मुहतात होकर खाना खाते हैं, चीज़ों को थोड़ा अवॉइड करते हैं, लेकिन बाज़ औक़ात ये है कि फ़र्ज़ करें आपको कुछ खाना बड़ी खुशी देता है, वो बात हो सकता है मतलब सेहत के हिसाब से ठीक ना हो। मतलब जैसे मैं मिसाल दे रहा हूँ, मतलब वो ये नहीं है कि जैसे आप फ़र्ज़ करें किसी वक्त आपका आलू वाला पराठा खाने को दिल चाहता है, या बर्फ़ वाला गोला आप कहते हैं वो ठीक है कपड़े ख़राब होंगे लेकिन आप खा लें, लेकिन आप रोज़ अगर खाएं तो वो ज़ाहिर है हर बंदे को पता है कि वो आपके लिए ठीक नहीं होगा। तो इसको ज़रा काइंडली फूड और ये मेंटल गेम को थोड़ा सा, इन दो चीज़ों को ज़रा।
और कुछ नहीं, मेरे मुंह में पानी आ गया आलू का पराठा सुनकर। साथ एक कड़क चाय भी होनी चाहिए लेकिन। देखिए, like I said before, whatever rocks your boat, ठीक है ना, लेकिन one needs to maintain moderacy, whatever they do, खाने पीने में, एक्टिविटीज़ में, हॉबीज़ में, इंटरेस्ट में, रिलेशनशिप्स में, काम पर, पैसे खर्चने में, the middle road is always the best road, moderacy in everything. तो हमें पता है, तो it's a given, isn't it? पराठा खाने का शौक अगर रोज़ खाएंगे 3 times a day तो it's not going to be good for you. So it's बाकी जो नजूमी वगैरह का बात, I don't know how to answer that question. मैंने कभी किसी नजूमी के पास, I don't know what kind of science they use, and I wouldn't know how to answer that one. Psychiatrists को कहते हैं कि psychiatrists बैठकर body language पढ़ लेते हैं. I wish I could. Lekin obviously, predictable. Obviously, one of the things that we do because of our training is that we often call to court by lawyers, solicitors, etc., especially in criminal courts. तो उसमें हमसे पूछते हैं कि risk के बारे में, predictability के बारे में. तो हमें previous history में, current mental state में patient से interview लेकर हमें हम ये नहीं कह सकते कि नहीं वाकई करेगा, लेकिन there are some predictive factors which we have to highlight. तो हमारी जो रिपोर्ट होती है वो उसी में बड़ा स्पेसिफाई होता है कि हम लोग रिस्क इंक्रीजिंग फैक्टर्स कौन से हैं, रिस्क डिक्रीजिंग फैक्टर्स कौन से हैं, करंट रिस्क्स क्या हैं, प्रीवियस यूज़ ऑफ ड्रग्स एंड अल्कोहल है उसका क्या इन्फ्लुएंस था, दोबारा यूज़ करेंगे कि नहीं करेंगे, करेंगे दोबारा ये होगा कि नहीं, उसका करंटली वो कि उनकी मेंटल स्टेट है, मेडिकेशन कंप्लायंस है कि नहीं है. सो यू ऐड ऑल दीज, दैट्स आवर साइंस, दैट्स हाउ वी प्रेडिक्ट. बाकी आई एम नॉट श्योर हाउ नजूमीज डू इट, टू बी क्वाइट ऑनेस्ट.
थैंक यू डॉक्टर साहब, ज़बरदस्त. एक तो मुझे ये बताएं कि क्या ब्रिटिश में भी कोई ऐसा है जो फिज़िकल फिटनेस के अलावा, मतलब अगर हायर अप प्रमोशन के लिए फिटनेस, फिज़िकल फिटनेस के अलावा और उसकी क्वालिफ़िकेशन तो प्लस होती है, कि मेंटल टेस्ट भी होता हो और उसमें उसको उसके कोई मार्किंग करते हो, किस चीज़ का, मेंटल हेल्थ का, उसका जिस तरह मोहतरमा ने बताया ना कि वो बाइपोलर है, एज्यूम किया जाता है वटेवर, तो इस तरह के कोई पर्सनैलिटी इश्यूज पहले असेस किए जाएं और उसको फिर उसके बेस पे उसकी प्रमोशन होती है. क्या वेस्ट में ये है, पाकिस्तान में तो ऐसा
साइकोमेट्रिक टेस्ट की बात करें, साइकोमेट्रिक टेस्ट है, you can do psychometric test.
नहीं, what I mean to say, this is any criteria for promotion upward in the government.
प्रमोशन के लिए नहीं होते, वो जॉब स्टार्ट करने के लिए.
हाँ नहीं, स्टार्ट के लिए तो ठीक हो गया, वो तो ठीक हो गया, लेकिन प्रमोशन के लिए तो कोई ऐसा
आप पूछेंगे होना चाहिए नहीं होना चाहिए?
नहीं, मैं कह रहा हूँ कि ये होता है, होना तो चाहिए ऑफ कोर्स, लेकिन होते कि नहीं होते.
माय अंडरस्टैंडिंग नहीं, वो कुछ और सवाल पूछे, वो कह रहे होते नहीं. आई डोंट थिंक, वो ठीक कह रहे हैं. आई डोंट थिंक एक दफ़ा जॉब जब स्टार्ट होती है साइकोमेट्रिक पार्ट ऑफ द इंटरव्यू प्रोसेस, आपकी साइकोमेट्रिक टेस्टिंग होती है, नॉट एवरीवेयर लेकिन होती है. लेकिन आई एम नॉट अवेयर, यूके में भी देख लो, पाकिस्तान में भी आप लोग काम करते हैं.
पाकिस्तान में तो नहीं है,
यूके में भी नहीं है. आई थिंक फॉर प्रमोशन हम देखते हैं, हम अपने when a trainee becomes, senior trainee becomes a consultant, when a consultant goes into management as a clinical director या socio-medical or medical director, there's no psychometric testing.
ठीक. अच्छा, कुछ जो एक साहब ने भी बात की है, वो जो लोकल एक्सेस की बात है, उसमें अगर जिस तरह पीर मुरीद और योगा वगैरह की बात है, एक तो ये तो साइको
पीर मुरीदी को योगा के साथ ना कंपेयर करें.
अच्छा, मेडिटेशन की मैं बात करूँ थोड़ा सा उसके हवाले से. अच्छा, उसमें जो दूसरे ड्रग्स हैं, मसलन भंग है या कोई आशीष है या कोई इस तरह की है जो कि टेम्परेरी आपको या कोई आपकी कोई जो एडिक्शन ना हो, जो एडिक्शन के तो फिर सिचुएशन डिफरेंट हो जाती है, तो क्या आप उसको कैसे देखते हैं एज ए साइकियाट्रिस्ट? उसको
फॉर एग्जांपल कोई भंग की
बात करूं या शीश की बात करूं या कोई भी टेम्परेरीली कोई,
देखिए ना, दे आर ऑल फ्रॉम द सेम प्लांट. जी, दे आर फ्रॉम द सेम प्लांट. देखिए, बहुत सारे लोग वीड, कैनबिस स्मोक करते हैं, कुछ भी नहीं होता उनको. लेकिन ये भी हमें पता है कि लॉट ऑफ पीपल जो हमारे पास जो लोग आते हैं जिनको ड्रग इंड्यूस साइकोसिस होता है, ए मोटिवेशनल स्टेट्स होते हैं, उनकी हिस्ट्री लें तो कि हाँ हम पीते हैं रेगुलरली, हमें ये भी पता कि उसकी वजह से हुआ है, हमें ये भी पता है कि जब उन्होंने जब उन्होंने कैनबिस या वीड छोड़ दिया तो वो ठीक हो गए, ठीक है। तो अगेन इट कम्स डाउन टू अ जेनेटिक, जो हमारे यहाँ पे वहाँ पे एक बड़े फेमस एक प्रोफेसर है, प्रोफेसर रॉबिन मरी, ही इज़ द गॉड फादर ऑफ कैनबिस साइकोसिस, ड्रग इंड्यूस्ड साइकोसिस का. So he's done a lot of studies, so do look him up. You'll find a lot of his talks. And one of the things that he does say कि हमारे genes में ना कुछ constructs होते हैं, कोई उनके जो हिस्से होते हैं जिसको MET and VAN शायद कहते हैं, तो उसका एक certain sequence होना चाहिए कि आप जब weed पीते हैं तो एक certain जो आपका जो वो MET है or something वो switch on हो जाता है, लेकिन वो एक certain sequence में होना चाहिए. जब वो switch on होता है, you are more prevalent to experience psychosis. That the same is the case with a lot of other things like heroin. They do not cause psychosis. They can cause the opposite. They can cause a calm, depressive phase. They can worsen mental illness, लेकिन they can't cause it. The drugs that cause psychosis, जो आपका probably आप पूछना चाहेंगे, cannabis, cocaine, magic mushrooms, any stimulant, LSDs, these cause mental health problems, particularly psychosis. Again, in which people lose contact with reality. Problem उसमें ये है कि नहीं, अच्छी बात ये है कि a lot of the people who do these, majority of them recover. There is a small fraction of people who don't recover, even if they stop taking the drugs. ठीक है? They go on to develop a longer term psychotic illness, which is a worry for us always. So this is a difficult one when we are talking to family, because we have to instill hope in families of when we know that it's drug induced, but also when we come to the conclusion that this is actually now going to be long term, unfortunately.
अस्सलाम वालेकुम. मेरा सवाल ये है कि अनफॉर्चुनेटली पाकिस्तान के अंदर सिर्फ 400 साइकेट्रिस्ट मौजूद हैं. अब रूरल एरियाज़ में मेंटल हेल्थ अवेयरनेस बिल्कुल ना होने के बराबर है. आप इसको एज आ साइकेट्रिस्ट किस तरह देखते हैं? गवर्नमेंट की कोऑपरेशन किस हद तक है यहाँ पे? और अब मुझ में एक इशू है कि सेल्फ टॉक मुझ में बहुत ज़्यादा है. मैं इसमें इतनी सेलेक्ट टफ है कि मैं आर्टिकल्स भी लिखता हूँ, लिखते लिखते मतलब इतना गुस्सा आता है मुझे. एक तरफ के हो तो कुछ ऐसी चीज़ें नोटिस करते हो जिनको नोटिस करने की ज़रूरत ही नहीं पड़ती मुझे. तो क्या ये कहते हो कि आप ये मेंटल इलनेस है मुझे?
ज़रूरी नहीं कि मेंटल इलनेस हो, लेकिन मैं ये सजेस्ट करूँगा कि इफ़ इट्स समथिंग जो काफ़ी अरसे से है और आपको बॉदर कर रहा है और आपको जैसे मैंने कहा था कि आपकी जो डे टू डे एक्टिविटीज़ हैं जिसमें आपको पार्टेक करना है, अगर उस पर इम्पैक्ट हो रहा है तो मेरी सजेशन आपको यही होगी कि डू गेट एन असेसमेंट, जस्ट टू रूल एनीथिंग आउट. ठीक है.
ये बताइए कि जो मेंटल हेल्थ के जो एनजीओस है पाकिस्तान में, गवर्नमेंट कितनी कोऑपरेट करती है उनके साथ?
जो
एनजीओस रूरल एरियाज़ में बिल्कुल ना होने के बराबर है मेंटल हेल्थ, जिसकी वजह से सुसाइड्स ज़्यादा हो रहे हैं.
डिसप्रपोर्शन तो है, क्योंकि मेजॉरिटी साइकाइट्रिस्ट्स हैं वो अवेलेबल ही सिटीज़ में, अर्बन एरियाज़ में हैं. ठीक है. एंड फॉर दैट रीज़न अ लॉट ऑफ पीपल इन द अर्बन एरियाज़, इन द रूरल एरियाज़ टर्न टू पीर्स एंड फकीर्स फॉर एनी काइंड ऑफ हेल्प. ठीक है. मैं जब यहाँ हाउस जॉब कर रहा था होली फैमिली हॉस्पिटल में, अभी तक याद है, सिर्फ मेंटल इलनेस में नहीं है, फिजिकल हेल्थ में भी है. मुझे याद है कि पर्सन वाज डायग्नोज विद लिवर कैंसर, तो जब उनको डायग्नोज किया तो उन्होंने जो हम उनको मेडिकेशन दे रहे थे उन्होंने छोड़कर चले गए वो. एंड वी सॉ देम अबाउट 3 months लेटर. तो हमें ये पता चला कि किसी पास गए थे गाँव वगैरह में, पीर वगैरह, वो पता नहीं क्या वो हार पर आए होता, चीज़ें ट्विस्ट करते हैं, अक्सर उसको सही पता हो, वर्क्स इन ऑन्कोलॉजी. तो दिस नॉट मेंटल इलनेस सिर्फ नहीं है, लोग अनफॉर्चुनेटली रिलाई करते हैं भी है. देखें, हम लोगों ने जब ये स्टडी किया था तो हम लोगों ने वी थॉट इट वाज वेरी इंपॉर्टेंट. वी बॉट एन इस्लामिक स्कॉलर, अ सेंसिबल वन. रीज़न उसका ये था कि हम लोगों ने कम्युनिटी को अवेयरनेस देनी थी. एंड व्हेन यू हैव टू गो इनटू द कम्युनिटी, यू हैव टू गो द राइट वे, अदरवाइज वो कहेंगे ये कहाँ साइकाइट्रिस्ट मुंह उठा के आगे हमें बता रहे हैं, यू नो, डे टू डे प्रॉब्लम. सो यू हैव टू हिट इट द राइट वे थ्रू द राइट व्हीकल्स. So there are a lot of there are some sensible people out there, and unfortunately majority sensible नहीं है. ठीक है. हमारे कुछ obviously when it comes to the amalgamation of culture and religion and sciences, you know, हमारा problem है ये. Problem ये है कि belief system is there. अच्छी बात है, करें. If it acts as a prognostic factor, it is really good. And you know, for a lot of people, majority of people, it helps. The problem ये है कि we then go in another direction completely, which actually has a counter. And ये सिर्फ पाकिस्तान में नहीं, यूके में भी है. हमारी पीरी फकीरी यूके में बहुत ज़्यादा. हम लोगों ने बहुत काम किया है इसके ऊपर. एक बीबीसी का एक प्रोग्राम था, उसका नाम था द बैक स्ट्रीट पीर्स और समथिंग. लंदन में एक जगह वाइट चैपल, वहाँ पे बांग्लादेशी कम्युनिटी बहुत ज़्यादा है. तो वहाँ पे वाइट चैपल में, तो वहाँ पे एक स्टडी हुई थी, बीबीसी का प्रोग्राम हुआ था. सो दे वेंट विद अ कोवर्ट ऑपरेशन किया था उन्होंने कैमरा के साथ. एंड वहाँ पे उन्होंने उठाया था कि हाउ पीपल, स्पेशली दोज फ्रॉम एशियन बैकग्राउंड्स, Muslims mostly, are taken advantage of by peers and fakirs. Black magic को कहेंगे जी ये प्रॉब्लम है, बेशक फिजिकल हेल्थ प्रॉब्लम्स ही हों कि आपको जी जिन चमड़ा हुआ है, जी आपको नज़र लगी हुई है, किसी ने जादू किया आपके ऊपर, and then they obviously take money and they do the necessary. हमारा एक और प्रॉब्लम है वहाँ पे, and that is अभी भी हमारी यूके में हमारी majority वहाँ पे जो पाकिस्तानी जो गए हुए हैं 60, 50, 60s है, from villages, मीरपुर वगैरह की साइड से, and lovely people. The downside is that they've spent less time on education, and they're very insular in a lot of ways, जिसकी वजह से we have to reach into them to educate the families. I think अब वो time आ गया, I think we are at a level where we can go into them, talk to them, get them to understand. वहाँ पे भी जैसे पाकिस्तान में अरेंज मैरिजेस होती हैं, लॉट ऑफ देम कम बैक टू पाकिस्तान, अपने विलेजेस में जाएंगे, ज़बरदस्ती शादी करवाएंगे. तो देयर वाज, यू नो, वी हैड लॉट ऑफ स्टोरीज अबाउट दीज मैरिजेस, अबाउट यंग लेडीज वांटिंग टू रन अवे एंड देयर पीर फकीर कम इन, उसको मेंटल इलनेस बना दिया. देयर पीर्स टेक एडवांटेज ऑफ दीज सिचुएशंस, पैसे लेंगे, एडवांटेज भी लेंगे. सो दिस इज एक्चुअली क्वाइट अ बिग प्रॉब्लम इन द यूके. इट्स अ बिग प्रॉब्लम, एंड दिस इज समथिंग दैट वी आर challenging with the Royal College, some of the work, लेकिन you have to do it very very sensitively, because इसमें आपके local community भी involved होती है, इसमें आपका local mosques भी involved होते हैं, इसमें you have to make sure you get the right people and do it the right way, because as they say, an intelligent man knows what to say and a wise man knows how and when to say it. So you have to be very very wise as to, or you know, very sensitive how you go in if you want to make a change. जी.
mental disease like change sleep cycle or sleepless change in body clock.
Last question करें. ये last question है ये. Insomnia is a symptom. It's not an illness. हम समझते हैं कि illness, it's not an illness. And insomnia can be secondary to a primary cause or a secondary cause, due to a physical cause, due to a mental health cause. Like, it's a symptom. Symptom of any of these causes. For example, अगर किसी को diabetes है, उनको परेशानी हो रही है, it keeps them awake. वो आदत पड़ गई है, it leads to something which we call insomnia. आदत पड़ जाती है. लेकिन देखें जो medication, लेकिन it depends कि कितने लंबे अरसे के लिए. अगर सिर्फ short अरसे के लिए, you can take short term medication with it to re-establish the sleep architecture, sleep pattern. एक और चीज़ जो बहुत ज़रूरी है इसमें, there is a big difference between insomnia and or sleep problems or sleep deprivation and sleep shift. A lot of people have sleep shift. वो क्या करेंगे, वो सुबह 3 बजे सोएंगे, सुबह 7, 8, 10, 11 बजे उठेंगे, कहेंगे मुझे insomnia, मुझे नींद नहीं आती 3 बजे. It's not insomnia. It's called sleep shift. So you just have to change the timing of it. So insomnia it can be a very very chronic issue and a problem. And medication isn't always the answer. Sometimes it's very dedicated psychological therapy, even if it's for a physical cause. And जैसे cognitive behavior therapy की मैंने बात की है, तो उसमें 3-4 बड़े अच्छे, लेकिन you have to be motivated and you have to be very committed if you want to make a change, because it's hard work. And मैं आपको example उसका एक दे देता हूँ. For example, एक चीज़ उसको कहते हैं sleep hygiene. Sleep hygiene is the very basics that you do within sleep. That is for very basic sleep problems. And that is how your room is ventilated, what kind of bed you're sleeping in, what kind of lights, for example, आपका फ़ोन ब्लू लाइट emit करता है, टीवी है ब्लू लाइट emit करता है which mimics daylight. तो याद है मैंने आपको पहले कहा था कि जो लाइट है आपके सेरोटोनिन को एक्टिवेट करता है. तो बेसिकली यू आर टेलिंग योर आइज एंड योर सेरोटोनिन इन योर ब्रेन कि इट्स daylight. You know, so these little things, so sleep hygiene has these within the process. There is a process and a science behind it. ठीक है ना. इसी तरह कहते हैं कि अगर आपको इंसोम्निया का प्रॉब्लम है, अगर आप बेड में लेटे हुए डोंट टॉस एंड टर्न. अगर नींद आपको नहीं आ रही, गेट आउट ऑफ बेड, बिकॉज एक्चुअली व्हाट यू आर टीचिंग योर बॉडी is that you can toss and turn and your body is getting used to that. So your body should be used to, and this is a deeper psychological process, your body should be used to being in bed to sleep. And if you're not sleeping, you should get out of bed. And when you feel tired again, come back. Lie down again for 15 minutes. If you can't sleep, get up again. It's a painful process. Lekin isliye maine kaha, this is just some of the basic elements to some of how to manage insomnia. But insomnia is always secondary to something. It's a symptom. It's not a core. It's not an illness. I think we're okay.
ऑनलाइन क्वेश्चंस.
अच्छा, ऑनलाइन क्वेश्चन.
थोड़ा सा आपका टाइम चाहिए होगा. हमारे ऑनलाइन भी देखने वाले कई दोस्त हैं. शॉर्ट रिप्लाई दे दीजिएगा. जवाद अशरफ जी डॉक्टर जवाद डार हैं हमारे साथ. उनका कहना है कई क्वेश्चन थे, मैं 2 रख रहा हूँ आपके आगे. डू ऑल इलीगल ड्रग्स कॉज मेंटल हेल्थ प्रॉब्लम्स?
नो, नॉट ऑल ऑफ देम. उसका मैंने जवाब भी किया था. इलीगल ड्रग्स कई किस्म के होते हैं. स्टिमुलेंट्स ज़्यादातर जो हैं वो साइकोटिक इलनेसेस क्रिएट करते हैं. आजकल यूके में there's something which we call legal highs. Legal highs are something which are more street drugs. उनकी जो ingredients हैं, they're a combination of drugs which are more potent and more problematic. लेकिन जो basic जो drugs हैं, for example, cannabis, majority of people, a lot of people smoke cannabis, and a lot of people get away with it and nothing, but very handful of people, it can cause a psychotic illness. So they have to be what we term as stimulants. And some of them are called hallucinogens like magic mushrooms, LSDs वगैरह.
अल्कोहल और साइकोसिस का आपस में कोई लिंक?
जी बिल्कुल हो सकता है जी. अल्कोहल ऑब्वियसली इट डिपेंड्स आपकी जेनेटिक मेकअप के. जैसे चाइनीज़ लोग हैं वो अल्कोहल को नहीं टॉलरेट कर सकते बिकॉज दे हैव a lack of an enzyme called alcohol dehydrogenase. तो वो थोड़ी सी वो पीते हैं ना, उनका alcohol break down नहीं होता. You see, so I'm just giving you an example of how different people from different backgrounds, how they react. So if you lack alcohol dehydrogenase, you will not break down the alcohol. That's why Chinese people, when they drink even a little bit of alcohol, they go red, they get flushed, and they can very easily get drunk from much more less than how other people will normally drink. Like an alcohol ka hai issue, there's something which we call alcohol hallucinosis. Okay, those people have alcohol problems, जिनको alcohol dependency syndrome है या alcohol abuse करते हैं, they can develop something which we call alcohol hallucinosis, and that is basically it's not very common, लेकिन when they do experience it, their predominant symptoms are visual hallucinations, and in the visual hallucinations the predominant symptom is they see little people, which are called Lilliputian people or something like that, which they see walking around. This is a give sign of alcohol hallucinosis. The other thing that alcohol can cause, which is slightly away from the psychosis, is something which you call Wernicke's and Korsakoff's illness, and that is basically more of a neurological process, which subsequently can cause mental health problems as well.
हारिस एजाज़ हैं, शायद आप इसके बारे में ना जानते हो क्योंकि आप यूके से आए हैं. वो पूछ रहे हैं कि इस्लामाबाद में मेंटल हेल्थ रिसोर्सेज कौन सी रेकमेंड की जा सकती हैं? आर देयर प्लेसेस वेयर वी कैन एक्सेस ECT और RTMS थेरेपी इन इस्लामाबाद? आई डोंट नो, अगर किसी के इल्म में हो तो वो कमेंट में इनको रेकमेंड कर दें. आदिल मोहम्मद जावेद हैं, ये सुपरस्टिशन, ये जो तवाहम परस्ती है और ये जिन्नात वाले मामले, उसका आपने जिक्र कर दिया है. एक ये क्वेश्चन है, मुझे नहीं पता ये, खैर मैं कर देता हूँ. सलाउद्दीन दरवेश का इन्होंने इंसिस्ट किया है कि मेरा सवाल ज़रूर पूछें. उनका कहना है कि उनके एक दोस्त हैं जो नशे के इंजेक्शन लेती हैं, लेकिन उनकी तख्लीकी सतह बहुत ज़बरदस्त है.
हमें भी बताए क्या लेते हैं.
अब ये वजाहत नहीं हुई कि नशे के बाद उनकी सतह बुलंद हुई है या उसको वो ट्रिगर होती है, बट
the only thing I would say कि creativity अगर उसकी वजह से keep away.
वो पूछ रहे हैं कि ही इज़ वेरी क्रिएटिव, लेकिन अचानक से उठ बैठते हैं, भूख लग जाती है, फैसला करते हैं, तर्क कर देते हैं, टिकते नहीं हैं, हिलते रहते हैं, यानी ही कीप्स ऑन swinging from one state of mind to the other.
Because of the drug he's taking.
Apparently yes. तो क्या ये बाइपोलर डिसऑर्डर है या शुड ही बी वरीड अबाउट हिज?
नहीं, अगर ये चीज़ें सारी हो रही हैं और उसके ड्रग के बगैर नहीं होती, तो obviously that drug is having some kind of impact on him. So yeah, so he needs to be very careful and conscious. And the other thing, obviously, he hasn't told us what he's injecting. Like, obviously, drugs, as we know by nature, not only are addictive but also cause what we call as tolerance. इसका मतलब ये tolerance का मतलब ये कि अगर आप 1 mg ले रहे हैं तो after a while it will stop working. So you would like 2 mg. जैसे alcohol का होता है. That's how people develop dependencies. Because if you drink 1 pint of alcohol a day, you won't get the same kick in 6 months' time. You will want 1.5 or 2 pints. तो इसी तरह वो tolerance develop हो जाती है. So tolerance is one thing, but addiction भी. So I think if whatever he is taking and it's causing these problems, yes, I would take it seriously.
One last question, डेढ़ हैं बल्कि छोटे दो. हारिस एजाज पूछ रहे हैं कैन यू ब्रीफली एड्रेस हाउ टू डील विद स्लीप शिफ्ट, और इसी तरह अली एजाज हैं, वो थोड़े से परेशान हैं, वो कह रहे हैं कि आप साइकोलॉजी की बात कर रहे हैं जबकि आपकी एक्सपर्टीज़ जो है वो साइकियाट्री में है. ये थोड़ा सा ये भी कोई अगर बता दें क्या ये थिन लाइन है.
सबसे पहले स्लीप शिफ्ट की the simplest thing to do, it's one of the easiest ones to treat, more easier than insomnia, and that is try to sleep earlier, and if you still can't go to sleep, then take some form of sedatives under expert supervision for a couple of weeks, so that you can readjust your sleep structure with the similar sleep structure, sleep architecture. So for example, अगर वो 3 बजे सो रहे हैं, 4 बजे सो रहे हैं, he takes the sleeping tablet round about 9 o'clock so that he can sleep by 10. And if it still isn't working, take it a little earlier, maybe increase the dose. Like, he needs to be conscious. The only purpose for taking the sleeping tablet is to go to sleep, not because they can't go to sleep and now they have to take medication for a long time. The medication is only there so that it can help them or assist them to go to, or aid them to go to sleep at an earlier time, so that the sleep shift goes like this.